I'm moving now to the second part of the program and talking about the innovative and alternative approaches in treatment. And the first speaker is Professor José Ignacio Botella Carretero. He is an endocrinologist at the Hospital Ramón y Cajal in Madrid and Associate Professor of Medicine at the University of Alcalá in Madrid in Spain. And he focused his research on clinical nutrition and metabolism, obesity, and thyroid and gonadal disorders. Thank you, Ignacio, for your contribution.
Hello, good afternoon to everyone. Thank you to the organization and thank you very much, Luisa and Dr. Carretero, for your invitation to participate on this talk about nutrition as a treatment component in all stages. These are my disclosures for this talk. As you see, malnutrition is a common problem among pancreatic cancer patients. Approximately 80% of patients with pancreatic cancer report weight loss at the time of diagnosis. And over a third have lost more than 10% of their body weight in the moment of diagnosis. So this is a very big issue. 2/3 of patients are malnourished with anorexia at the time of the first consultation. And when facing the follow-up, additionally, 70% of patients develop malnutrition during chemotherapy. Impaired nutritional status etiology is multifactorial. We have several issues such as anorexia, the obstruction for gastric and biliary flow, malabsorption after operation, or treatment side effects of chemotherapy, and also the release of tumor cytokines. As weight loss greater than 5% has been associated with higher surgical infection rates and longer hospital stays in the case of patients undergoing surgery. And as you can see here in this picture, the lower the body mass index is in a patient and the higher the weight loss, the lower is the patient's survival overall. So therefore, identifying patients at risk of malnutrition and delivering the most appropriate and early interventions may be beneficial for both patient outcomes and also for the quality of life. Just in the 2017 guidelines, European guidelines for nutrition in cancer patients, the authors stated that both screening for malnutrition and nutrition interventions are not only important when facing cancer cure at the beginning of the follow-up of the patients, but also for those cancer survivors and for cancer recurrences, and also in palliative care. We should be performing all the time screening and nutrition intervention in each stage. I'm going to refer to a specific point raised by the very recent European practical guidelines in clinical nutrition in cancer, and also in this paper, which is an expert consensus in which I participated together with Professor Carretero. And this paper has been published in 2022 in Clinical and Translational Oncology. And the first thing that we have to bear in mind is that screening and assessment has to be performed regularly in all patients from the beginning of the diagnosis. And if those patients with a normal screening, an assessment of nutritional intake, nutrition impact symptoms, the muscle mass and physical performance has also to be done in these patients. Regarding energy and requirements, the total energy expenditure of these patients has to be similar to healthy subjects. And if you do not perform indirect calorimetry, which is the gold standard, you can generally calculate them as between 25 and 30 kilocalories per kilogram per day. Protein intake should also be high. above 1 gram per kilogram per day, and if possible, up to 1.5 gram per kilogram per day. And also do not forget to give patients vitamins and minerals in the amounts approximately similar to the recommended daily allowances for a healthy person. The guidelines also point out a recommendation to increase the ratio of energy from fat to energy from carbohydrates in those patients with insulin resistance as to reduce the glycemic load. Regarding screening, there are different nutritional screening tools. Most of them are recommended by the European Society for Clinical Nutrition and Metabolism. But in the paper that I showed you before, in this expert consensus, we recommended the Malnutrition Universal Screening Tool, the MUST tool, because it is very simple. It is not time consuming, and you don't have to be a nutritional specialist to go with it. So even if you're a surgeon, oncologist, or a radiotherapist, you can do it in the moment that you have the patient in front of you. It involves 3 simple steps. Step 1 is to record the body mass index, the BMI. Step 2 is to ask the patient for unplanned weight loss in the past 3 to 6 months. And step 3 is to see if the patient is acutely ill and there has been or is likely to be with no nutritional intake for 5 days. With these 3 steps, then you get a score, and you classify your patient in a low risk category, medium risk, or high risk. And it gives you some management guidelines for hospitalized patients or for community patients. And it is clear that for high-risk patient, it is mandatory to treat, to start some kind of nutritional therapy. Regarding the nutrition intervention, the first step is always to increase oral intake. First, with dietary advice, but always offering patients oral nutritional supplements. The second step would be to recommend enteral nutrition if oral nutrition remains inadequate. And always do not forget to increase the amount of energy and the nutrition through several days to avoid the refeeding syndrome. And for those patients with chronic insufficient dietary intake or uncontrollable malabsorption, it is recommended to give them a kind of whole enteral nutrition or even parenteral nutrition in selected cases. As Professor Carretero already said, do not forget to recommend exercise to support muscle mass. In fact, the European guidelines recommend to individualize resistance exercise in addition to aerobic exercise to maintain muscle strength and muscle mass. For the consensus paper that we published, we provided several algorithms for the nutrition medical treatment according to the pancreatic cancer status. This first algorithm is for resectable or borderline resectable patients, which represent approximately 20% of patients, and has been already said. Here, depicted by triangles, you're going to find the moments when you should perform a nutritional screening and nutritional assessment. And here, represented by the stars, are the moments in which you need to give the patient some kind of nutritional intervention. Regarding the recommendation for neoadjuvant therapy, just want to point out this recommendation number 11, which deals about the prophylactic gastrostomy or nasogastric tube, which we do not recommend as a general procedure for all patients. We think that each case should be individualized according to the severity of the patient's nutritional status and their ability to sufficient oral intake. Regarding surgery, it is very important preoperatively to give oral nutritional supplements for those patients at risk of malnutrition at least for 5 to 7 days before surgery. This measure has shown to reduce post-surgical complications, especially infections. And also consider those patients with severe malnutrition to delay surgical procedure for 7 to 14 days until their nutritional status recovered. Always a recommendation is to include the patients in an enhanced recovery after surgery and errors protocol at your institution. Postoperatively, it is very important the early onset of oral tolerance and the use of postoperative oral and enteral nutrition. This is a strong consensus in the paper. And in the case of postoperative complication, you might use enteral nutrition through a nasoyunal tube, for example, or use early parenteral nutrition. For those patients with locally advanced cancer at the moment of diagnosis, well, the same recommendation as for neoadjuvant treatment are stated. And finally, for those with metastatic disease, several recommendations, we gave several recommendations, but mainly the need for individualized nutritional therapy in these patients. Recommendation 21 points out this need for individualize the patient's clinical scenario. And it is also important that those patients in palliative care might also benefit from some kind of nutritional therapy. And especially in those patients with locally advanced or metastatic cancer with a life expectancy greater than 3 months, who present intestinal obstruction or even pseudostructure, you might consider home parenteral nutrition to improve quality of life and in some studies also survival. So even in patients in palliative care, there's always some nutritional therapy that we might offer them. And thank you very much for your attention.
Yes, thank you very much, Ignacio, for these introductions to the importance of nutrition in treatment. And I would like then to inform the audience that PCE is working right now on a nutrition project, preparing infographics to inform patients, carers and professionals on the importance of nutrition in facing this illness. Yes, it's now the turn of Dr. Riccardo de Robertis, Lombardi. He is assistant professor of radiology at the University of Verona in Italy, and he has a PhD degree in inflammation, immunity, and cancer. And he produced several publications in international journals regarding diagnostic and interventional radiology in hepatobiliary malignancies. Thank you, Riccardo, for your presentation.
Thank you very much for your kind introduction, Luisa. And it's a pleasure to be here with you. Can you see the presentation?
Yes.
Okay, very good. So in the next few minutes, I will talk to you about some principle and our experience in percutaneous ablation of pancreatic cancer. Percutaneous ablation is an established treatment modality for both primary and metastatic tumors of several organs, such as the liver, of course, the kidney, the lung, and the bones. On the other hand, percutaneous ablation of the pancreas is far less commonly performed, and it has several important peculiarities. First of all, pancreatic ablation must be accurately contained into the tumor mass in order to preserve the surrounding structures, such as, for example, the duodenum or the mesenteric vessels that may be damaged during the ablation with relevant complications. And second, since most patients with pancreatic cancer already have or will develop metastasis briefly over the course of their disease, we must find the right place for ablation in the multimodality approach to this patient. And probably in the next talk, Salvatore Paiella will suggest something about that. Indeed, shortly after its first application as a salvation tool, let's say a salvation tool for patients found to be unresectable intraoperatively, pancreatic ablation evolved through minimally invasive approaches such as the echoendoscopic and the percutaneous ways were developed. These two are absolutely faster and cheaper than open ablation, and they minimize the length of hospital stay and the risk of complications related to laparotomy. Among the several options for percutaneous pancreatic ablations, radiofrequency ablation and irreversible electroporation are the two most important techniques. Each of these options has its own particular characteristics, advantages, disadvantages, and contraindications. Let's start with the radiofrequency ablation, which is probably the most the oldest and most common modality for ablation, especially for the liver. Radiofrequency ablation induces coagulation necrosis of the tumor mass by delivering high-frequency alternating current fields that produce a frictional heating of the molecules that compose the tumor tissue. There are several advantages of percutaneous RFA. First of all, we don't need the general anesthesia. Patients can undergo only deep sedation. We use thin needles, 17 gauge, but most of all, the most important advantages of RFA is that this procedure is really fast. The overall procedure, I mean, starting from the sedation towards the end of the procedure do not take more than 30-45 minutes, and is also very cheap. Two important disadvantages of percutaneous RFA are the so-called heat sink effect, which means that peripancreatic vessels may reduce the effectiveness of this procedure by dissipating the heat. Moreover, we have a limited control of the ablation area. I mean, the extent of the necrosis induced by RFA may be difficult to assess, especially during the procedure. Therefore, there is the theoretical risk to damage the peripancreatic structures, or on the other hand, to have an incomplete tumor ablation. Basing on our experience, we prefer the ultrasound guidance to perform percutaneous RFA, even though in the other centers the CT guidance is frequently used. And most important, we found that during our experience that the volume of necrosis within the pancreatic tumor is unexpectedly larger than using also a very small electrode exposition and a very low radiofrequency power. And this is very important because we can achieve a larger necrotic volume while minimizing the complications to peripancreatic structures. Here's an example. This is a patient with a pancreatic body tumor. As you can see, the procedure was performed on the ultrasound guidance with this very small electrode. First of all, we evaluate the whole tumor, and in particular the relationships between the tumor and the peripancreatic vessels in order to minimize the complications. And in the images below, you can see the needle which is inserted into the tumor and the progressive development of intratumoral gas, which is a sign of tissue carbonization and effective ablation. things may not be so easy. This is an example of a difficult tumor, which was difficult to reach by using the standard ultrasound equipment. And in this case, we performed the ablation using the so-called fusion imaging. We can overlay the CT, MR, or PET-CT images with the real-time visualization with the US, and by fusing these two images, we can choose the better way to ablate the tumor. Again, another example, you can see in the CT image a pancreatic body tumor with peripheral retention cyst. The tumor was ablated percutaneously under US guidance, as you can see in the US image. And this is the stick control. As you can see, the retention cyst on the left is located very near to the tumor ablation area. And again, another example, this was a clearly locally advanced tumor with the infiltration of the splenic artery, and the tumor mass reaches the celiac artery. The tumor was ablated percutaneously, and as you can see in the images, there was a very large necrotic area within the tumor mass. So by resuming our experience with percutaneous RFA, we treated 35 patients. We didn't find any procedure-related complication. Most important, we found that the necrosis size was, the mean necrosis size was 75% of the whole tumor mass. In terms of effectiveness, we had a decrease of stability of the CA-19-9 blood levels at 30 days after the procedure, and the mean survival after RFA was around 300 days. Moving to percutaneous IRA, irreversible electroporation is a non-thermal ablative technique that uses short, high-voltage electric current fields that induce the reversible permeabilization of the cell's membrane with the disruption of cellular homeostasis, stimulation of the apoptotic pathways, and finally induction of the death of tumor cells. IRA has three very important advantages. First of all, being a non-thermal ablative method, it is unaffected by the heat sink effect. Second, as the current do not run through the extracellular matrix, peripancreatic structures such as the bile ducts, or more important, as you can see in the figure, the peripancreatic vessels, which are rich in extracellular collagenous and elastic fibers, remains intact during the ablation. And third, we use very thin needles, 19 gauge. The most important disadvantage is that this procedure must be performed under general anesthesia using also neuromuscular blocking drugs. So we need an important effort by the anesthesiologist, and moreover, this procedure is pretty expensive. We don't have a very large experience for percutaneous IRA, so I must rely on literature data. What about feasibility and complications? As you can see from this review, pretty old, 2017, despite a certain degree of heterogeneity between studies, percutaneous IRA seems to be feasible in most cases, more than 85% of technical success rate. It seems to have a recurrence, both on recurrence-free survival and overall survival, Nevertheless, if you look on the bottom, the post-procedure complications rate seems to be significantly higher than RFA. The most important studies performed on percutaneous IRA are the PenFire series. Particularly if you look to these results from the PenFire 2 study, promising results are associated with IRA. Patients were randomized to FOLFIRINOX and percutaneous IRA or percutaneous IRA alone. And as you can see from the curves, there were no differences in terms of median overall survival between the two groups. And what is more interesting is what the PenFire 3 study is designed to, because the authors wants to evaluate the stimulation of tumor-specific immune response after percutaneous IRA in metastatic patients. So we come to the conclusions. Percutaneous ablation of pancreatic cancer is feasible, is relatively safe, and it's a very attractive, minimally invasive treatment for pancreatic cancer, but needs experienced hands, needs experienced interventional radiologists, and most important, multidisciplinary evaluation of the patients in order to identify the optimal candidates to this procedure. Thank you very much for your attention.
Thank you very much, Riccardo, for your interesting overview on less invasive methods to treat pancreatic cancer. And I'm now ready to pass on Professor Salvatore Paiella. He's Associate Professor of General Surgery at the University of Verona in Italy. And he has a PhD degree in inflammation, immunity, and cancer at the University of Verona. And his research focuses on pancreatic cancer treatment, particularly on the effects of tumor ablation on the immune system in pancreatic cancer patients. Thank you, Salvatore, for your presentation.
Hi, good afternoon, everyone. Thanks for inviting me. Thanks, Luisa. I will discuss open ablation of pancreatic cancer. I am a surgeon, and this is what I do, not routinely, but what I'm interested on. I have to say that considering the evidence-based pyramid, we are not at the tip of the pyramid, since we are still waiting for some ongoing randomized controlled studies to be completed. And I have to say as well that I will talk about locally advanced pancreatic cancer only, so no resectable disease, no metastatic disease, including also the borderline resectable disease, namely those pancreatic cancers that infiltrate peripancreatic vessels with various degrees of infiltration, both arteries and veins, or only arteries or only veins. According to the pancreatic adenocarcinoma NCCN guidelines, a patient with a locally advanced pancreatic cancer should not receive surgery upfront. Chemotherapy is the first choice always. And the patient should not receive neither ablation upfront, as we have recently confirmed using the only available randomized controlled trial published so far on ablation of pancreatic cancer. But why ablation? Because few locally advanced pancreatic cancer patients receive surgery. And so we thought at the early years of 2000 that it was necessary to focus our attention on this very huge slice of this pie. Look at the red parts. Those patients with local advanced pancreatic cancer in the red areas will never receive surgery according to the most common the most common study population, and just a quarter receive surgical aspiration, and within this group just maybe two-thirds receive radical resection. So what happened to the remaining group of patients? They receive chemotherapy and or radiotherapy at all. So we thought that investing research on tumor ablation was worthwhile. Additionally, we understood later on, thanks to many meta-analyses, that the pancreatic surgery in presence of veins and arteries infiltration is very demanding, is frustrating, and is full of postoperative complication and with high rate of mortality, with frustrating survival results. And they are even more frustrating if we think about pancreatic surgery with arterial resections. So the rationale of ablation was to produce local tumor cytoreduction, to obtain a local control of the tumor growth, hopefully, and to stimulate the immune system against the tumor, as many clinical and preclinical studies are demonstrating currently. At the very end, we offer palliative treatment to patients when radical surgery is unlikely achievable and chemo and has completed its role. So let's think about again the slides. We can say that patients potentially treatable with ablation are the vast majority of locally advanced pancreatic cancer patients. Which ablation should be used? There are many types of ablation techniques according to different types of energy. The technique, whoever it is at first used in the open setting in the operating room, then is possibly developed within a minimal invasive scenario. The reversible electroporation, as Dr. Robertis has said, is one of the most adopted one worldwide. It is a multi-probe technique. Electric fields are created surrounding the tumors, and the tumor cells die, preserving the peritumoral cells, including the vessels. This is the 3D reconstruction of what has to be done to produce an effective ablation. But this is real life. And trust me, it is quite difficult to put those needles at the right depth, at the right distance, one between the other. What about oncological and surgical results? It is hard to admit the whole efficacy of IRE, since not all patients will benefit from the application of IRE, because IRE has to be contextualized and has to be inserted within a multimodal pathway that involves a locally advanced pancreatic cancer patient. Looking at those survival rates, we can say that 28% at 2 months from 24 months from diagnosis is not a frustrating result, but it's something we have to still make research on. But we cannot forget that major complications and death events may occur with the high rates. Look at these numbers: 20% of major complications and 3% of mortality. Numbers very similar of the traditional pancreatic surgery. Probably one of the most interesting role of irreversible electroporation is the synergistic combination of IRE and other drugs, because it seems that the immune system is stimulated to react against the tumor. So other drugs are able to produce a more anti-tumor effect, chemotherapies, immunotherapies, oncolytic viruses, and other drugs. And clinical studies are demonstrating it, and we are waiting for the study already mentioned by Dr. De Robertis Lombardi from the Netherlands. The radiofrequency ablation instead is a single probe technique that uses heat to destroy the tumor cells. What has been obtained so far in terms of oncological and surgical results? Looking at the many papers that have been published so far, we are talking about 45 to 50 to 60 papers dealing with the IRE and less frequently with RFA. Some results are encouraging, because if you look at these overall survival rates of locally advanced pancreatic cancer, they are pretty encouraging. However, we cannot forget that other reports are not so good, and there are also results not so encouraging, also in terms of surgical results. Look at this 13% of mortality in that Dutch study that was conducted in 2017. Open ablation takes place also to test a new ablation technology, as I told before. In 2020, we completed with our friends from Marseille in France the trial on the laser treatment of pancreatic cancer. It was a safety and feasibility study, and this was the theory. There was an optic fiber, a temperature probe, and this optic fiber should have been able to produce a very slow going low temperature that was able to stimulate ultimately the immune system. However, the real life was more complex, and it was very, very difficult to put the optic fiber and the thermistor and the probes in the proper way, at the proper depth, at the proper distance. And additionally, we reported a very high rate of major complications. So we abandoned the idea to perform further research on this ablative technique. Just these messages to the insiders, to maybe the surgeons that are listening to me, that are attending this conference. Margin accentuation is something very novel, despite being in the ground since 2014. These authors from the United States of the group of Professor Robert Martin thought that it was useful to applicate the reversible electroporation right where the microscopic invasion of the tumor exists at the final pathology, the so-called R1. And in 2021, the MACPI study from the UK was published, and the author published a very low rate of R1 resection. We are talking about pancreatic duodenectomy with a 30% of R1. And if considering that R1 is the R parameter is a surrogate of survival, we might have been expected very more encouraging results. However, they compared the population with traditional pancreatic duodenectomies, and they found no differences in terms of overall survival and disease-free survival. So it's likely that a longer follow-up is needed. I can propose a decisional algorithm. Locally advanced and borderline pancreatic cancer is referred to the oncologist up front. If the CA19-99 levels are reduced or stable, if imaging shows no progression, if the clinical conditions are good, and if a radical surgery is not plannable at all, then a percutaneous approach, as Dr. Robertis has said, can be thought. If not feasible, then open ablation is an option. But if radical surgery is plannable and the surgeon intraoperatively finds an extended disease with an extended vascular infiltration, then open ablation takes place as a salvage procedure. Which technique should be adopted? If we consider a mass-forming tumor, probably a single probe technique, hopefully with a minimally invasive approach, percutaneously or via endoscopic ultrasound, may be adequate. But what about a tumor that is some sort of a cast around the superior mesenteric artery, such the one in this slide? Probably irreversible electroporation in the operative room may be more adequate. To conclude, we can say that open ablation, as well as percutaneous ablation, can offer a cytoreductive treatment to a stable, locally advanced pancreatic cancer, unlikely treatable with an R0 radical resection, and that ablation is always decided within a multidisciplinary setting. It should never be done up front, but only after induction chemotherapy, at least 4 to 6 months, or it can be done as a salvage procedure intraoperatively. Experience is necessary because complications, even deadly or life-threatening, may occur, and the minimal invasive approach that is repeatable should be always favored. When it's not feasible, then the open local ablation within research protocol is may be appropriate. Thank you very much.
Thank you, Salvatore, for this interesting overview of these innovative procedures, and also for the suggestions that you are giving at the end.